Watch out for the snakes, yeah, watch out for the... I seen all the signs, I seen all the signs. They've been telling lies, they've been telling lies. Watching how I move, watching how I move. I've been keeping track now, watch out for the snakes. Watch out for the...
So I'm sitting here at the end of my vacation. I've been spending a few days out here in Costa Rica, having a wonderful time, enjoying this beautiful country as well as the interior, the rainforest and all that stuff. But anyway, vacation's over and I'm now heading back to Boston. I'm going to be going out to the AAE meeting, American Association of Aeronautics meeting in Denver, immediately after I arrive. So vacation's over and straight to work, since I have to give a presentation over there at the AAE on the topic of perforation repair. Now, I am unfortunately a little bit of a procrastinator, so I still haven't prepared my presentation coming up in a few days. So what I did is I actually posted a quick Facebook kind of a shout out to see if anybody had any specific perforation cases using the putty to be willing to share with me. Wonderful, overwhelming response. A lot of people, you guys sent me cases to share, and I wanted to really appreciate and thank you all for sending me these cases. I will select a few of them and then show them at the AAE meeting during my presentation, of course, giving you guys full credit. Also, I figured, you know, why not? Maybe since the whole thing's starting here now, I'll take you guys along this journey with me. All right, let's go along. So I made it here out in Denver a day earlier because I've been selected to be part of an ADA's Instruments and Materials Standards Committee. So it's a little committee where they talk about the different standardization. We're trying to now use the ISO standards and the ADA standards and combine them together for international use. It was very interesting. I basically spent 5 hours in this conference room. I obviously can't show you the footage, but we discussed the nuances of all that stuff that we read in the dental materials books and so on about ADA and ISO specifications and how they come about. It was very fascinating. The ADA and the ANSI standards and the ISO standards in the past for setting time and the expansion time and the compression time, all kinds of things associated with the sealers were based on the older generation of sealers that were hydrophobic, and they were very different. Now with the advent of these new calcium silicate type sealers, then the thing has changed obviously, so they have different properties. These are hydrophilic compared to the other ones. So we're trying to change those standards to account for these, because almost on regular basis I get emails from some of you guys online who is asking, referring to one study or another that's been all benchtop studies that show that the bioceramics have issues with the setting time or with the solubility. Let me just quickly tell you that all of that is based on the fact that they use ISO standards that do not apply to the bioceramics, and that was purpose of this committee's meeting and so on, to set these standards right, so this newer generation of sealers and cements can be included. And the previous generation was all on hydrophobic material. So all of those results of those studies that have been done using the previous generation of ANSI standards for solubility and set and all those stuff do not apply because they've been using the wrong standards. Anyway, let's get back to the meeting. I spent 5 hours sitting behind the desk and talking about you know, tip sizes and taper of instruments and all kinds of interesting stuff. And by the way, another thing is changing is our definition of where the D0 and D1 is on an instrument. Lots of exciting stuff. Anyway, well, it's the next day here, and now the AAE is in full session. The exhibits are open, the courses are going on. So let's go ahead and check it. Well, here we're at the meeting here at the AAE. And who else am I with? Mr. Alfaro is here having a good time.
I'm not filming.
What's going on? I am filming it. Oh, yeah, I am filming it.
Well, we're having a good time with Andy and Jack, our classic photographers. Yes, 30.
Still a resident at the NYU program?
Still a resident, almost done. Couple
There
months
we go.
left. Yeah.
Couple months left. What's the plan afterwards?
Private practice.
Private practice. It's the way to go. No DSOs?
Yes, maybe.
We're going to cut this part out. What's going on? How are you doing?
Good, and you?
Have you guys seen the, so far, what have you seen in the meeting?
We've seen the new J. Morita cone beam machine.
Oh yeah.
It's fantastic.
Did you like that?
Amazing. Cuts down artifacts, higher resolution.
And it's going to be in my office.
Is it?
Yeah.
Yes. Finally.
Oh, finally I had to succumb.
I've been excellent. Very
So
well.
last year also at the AAE meeting, what have you seen so far in the meeting that you like?
Seeing a lot of the new stuff. I'm seeing a lot more people get into the bioceramic sealers. I see that
They're doing the right move.
there's other, you know, there's other companies that are
Yeah,
stepping
they're
into
coming
it.
up to it as well. Yeah, they're all
so-
over the place.
So that's
Bioceramics is the future, man.
yeah. So that's what I'm saying about the bioceramics cone beam. They got all new things and new algorithms that kind of help you read them better.
Terrific. Thank you so much. See you. All right. Terrific. It was a great meeting with the inventor of the Endosyncanths. Well, I guess I'm here at the Morita booth here, and look at the new X800, which I'm going to be having in my office soon. So. Everybody knows.
Couple of old
the
friends
legend,
right here, absolutely.
Dr. Ben Johnson. Dr. Kosh, obviously we all know as well. Dr. Johnson, you enjoying the meeting?
I'm enjoying the meeting. And I'm also looking for a job.
Well, we will end though, we're looking for great talent. The big and famous and the squash master here, Dr. Ian Grayson from our school. Ian, you were just taking a look at this Zyscope here, the Xara. You're telling me the benefits. How would you summarize the difference between this Xara unit versus the, I use the Opti Pico one.
Right. The Xtaro, for one thing, has slightly better quality optics, that's for sure. Number two, ease of use, ergonomics. It's also got another feature where it's got fluorescence, and with fluorescence, you can differentiate while you're working on a tooth between composite and enamel or dentin, and between caries, enamel, dentin, too much of the tooth substance. So it's great for tooth conservation.
Features are very important when you're doing microsurgery. To have a nice little elbow rest is going to save your rotator cuffs down in your career. So one of the great things about the AAE meetings, obviously all the social stuff that goes on, but there's also some of the poster clinics and the research that is always here. So it's a good opportunity for learning. And let's take a quick look at this one poster, for example, from Texas A&M University. It's about post-intentional reimplantation stabilization techniques. So how do you keep a tooth after you're doing your intentional reimplantation inside the tooth? And for example, one option is rib-on in areas where you can place a rib-on. You can even place a perio-pack in situations. You can also place some of these sutures, cross suture splint or a figure 8 splint with using sutures to stabilize the tooth that is moving a little bit. They have also an option for the wire splints, which I think is pretty cool. And what they've done is they've passively placed a non-rigid memory-less kind of a wire, stainless steel wire that is doesn't have any memory. And then what you're doing is you're kind of holding it in place with floss passively, and then you place and cure composites on those areas. And last but not least, vacuum formed stents, which are prepared in advance, obviously, before doing your intentional reimplantation case. So lots of different types of articles on the calcium silicate cements. An interesting one about the clinical use of NiTi files and their separation rates. An interesting one that they found in this one clinic. Instruments were being used 8 times prior to tossing, and I personally don't use the NiTi files that many times. You know, you don't want to separate files. My rate of file separation is very low because of the fact that I try not to use files too many times. Okay, so here's another interesting case at the University of Texas Health. Evaluation of obturation efficacy of single cone and continuous wave of condensation technique. And they've done a basic analysis and the comparison, and guess what? The conclusion finds that there was no significant difference between continuous wave of condensation and hydraulic condensation. Pretty cool. And for a little piece of history, here we have the Harvard Alumni Dinner this year at the Buckhorn Steakhouse, always in historical places. This is a 3-century-old steakhouse, one of the original ones. Want to take a look?
Story to tell.
You gotta tell a story.
Hey.
Hi, how are you?
Good. Welcome to the Buckhorn.
Thanks.
Go ahead upstairs and through the bar and you're in the back. You're welcome to walk around as much as you like.
Awesome. Yeah, look at this gorgeous place.
I come here all the time.
Is it okay to film a little bit of this stuff? Wow, look at this. Now that is real.
Farewell to the mountain whose mazes to me were more beautiful far than Eden could be. The home I redeemed from the savage and wild. The home I have loved as a father his child. The wife of my bosom, farewell to ye all in the land of the stranger. I rise or I fall. Farewell to the mountain whose mazes to me more beautiful far than Eden could be. The home I redeemed from the savage and wild. The home I have loved as a father his child. The wife of my bosom, farewell to ye all. In the land of the stranger, I rise or I fall.
Okay, finally done. Alrighty, alright, so it's about an hour and a half left to my presentation, and I finally put the last couple of slides together. As you can tell, I'm a big time procrastinator heading to the talk, but I'm gonna probably stop by at the exhibits one more time to see what's going on there. Dr. Terry Pancook, I'm sure you all know him from Pure Dental Learning. Great clinician and academician. So Terry, you've been standing up for endodontics all your life. So it's really wonderful to see you here at the meeting. Is your meeting going well?
It's going well.
Sure. Great to see you.
This is something that we need to take care of. As long as it doesn't give you enough time, look at this huge lesion here.
And that takes me to this final quote by our previous program director at Harvard, the Harvard Foresight program, by Dr. Alvin Krakow. It says, never leave a patient worse off than how you found them. And that is so key. And thank you all for your attention. Look who I'm here with, Dr. Adam Azim, Dr. Steve Buchanan, and Shervin Golian. Dr. Buchanan, how are you doing? Wonderful presentation today. It was awesome. You have the bioceramic, high flow coming out here, so we can have now the benefits of using the bioceramic technology with warm temperature condensation and the continuous wave of condensation.
It's a little short one though. The great thing about bioceramics is you're doing a 3mm down pack and that's all you need. You just need to push it a little bit so you can get around those MB2s that split off and go 7mm.
Alrighty, well, it's the next day and the presentation's over. It was a long day yesterday, and so that part of it is done, and now I'm gonna go just grab a little piece of coffee, and I want to maybe head out and visit the city a little bit, do a little something and see what's going on. Seems like the conference is dwindling down, and look at this guy. Hey, Sarum, Dr. Alvaro. How you doing? Hey, what's going on? How are you? What you doing? Having a little coffee too? Have you had breakfast yet? No.
You didn't have breakfast yet?
No. You want to eat something? Yeah, I was gonna go see the city a little bit. Do you have any place?
There's one place, Central Station, or Union Station.
Union Station.
And I always wanted to take that little train. There's like a little tram that takes you there. You want to join me?
No, let's do it. Let's go.
Come on, let's
You're
go.
free, let's go.
Yeah, let's go.
All right.
Jonathan's sleeping anyways.
All right. Oh, we got a little partner in crime. Let's go check out the city.
Are you filming?
Yeah, sorry. Is that okay?
No, it's okay. We'll just hop in.
So Manny, yesterday when I ran into you, we were talking about some premolars and the difficulty in diagnosing and looking at an x-ray of a premolar, finding out what's going on.
Yeah, lower premolars.
Lower premolars, right?
Premolars,
Any tips or tricks for our audience?
What I tell people, what I recommend is just always taking two angles, two periapical angles, at least a 40 degree, one straight on and one 40 degree, because they're so misleading. Lower premolars. What do you find lower premolars? Are you scared of lower premolars when you get
No, of course.
I'm afraid of lower premolars.
Lower premolars, they could be
are
either the easiest teeth in the mouth or they could be the hardest.
They're harder. They're misleading. They don't.
And the main issue is the fact that the anatomy is so aberrant in a small percentage of cases. And in those cases, you end up having, one canal splitting to two, or 3 roots or 3 canals. It's pretty tough.
And when they split right on the lingual buccal dimension. So you get this H type of thing coming up to you from the buccal. So you don't see it on the radiographs. You have to take those different angles.
That's the trick thing that was right there, is make sure you take an straight on x-ray, an angled x-ray, and a vertical bite wing anytime you get started with any case. And that's really the take-home message here.
And to go in with your axis, go in more buccally, because that's where the anatomy usually shows up. Not a misleading teeth. Those are teeth where you have to really look and understand the anatomy first, because that's gonna really put an effect on the prognosis of your root canal treatment. So we're going to Union Station. It's a landmark here in Denver.
One of the oldest train stations in this area?
I'm not sure.
Sounds good. Alright, so we've come here and we're sitting at a restaurant about to have a little breakfast. Manny, great idea to come down here. Union Station is beautiful, obviously. So Manny, we're talking about the premolar cases, and you had a case that you wanted to share with me on your iPhone, and it's an interesting case. You want to tell me a little bit about it?
Well, there's the one, like we spoke, the premolars, lower premolars are very deceiving because the anatomy can look simple. You have to take a couple of angulations. A good angulation is a 0 and a 40 degree, like as we know.
Exactly.
There's one
straight on 12-degree angle or something like a 12 to 15, and then a vertical bite wing. Vertical bite wing is so important for access, don't you think so?
Yes.
It gives you a chance to know how far you have to go before you get to
something I don't do often enough. Something I should do more often.
Yeah, it's so important because you could also tell the quality of the coronal seal and the restoration that's present, and what it has to be. Restorability, I mean, that's the key thing. You know, how far is the decay from the crestal bone? That's something periapical won't tell you. Vertical bite wing is the way to go for us. I mean, you know, general dentists take a regular horizontal bite wing because they want to get a bunch of teeth into one x-ray. But for us, where we're concerned about one tooth at a time, a vertical bite wing is the best way to go.
That's something I heard often in this convention about bite wings.
Vertical bite wings.
The whole issue of restorability is so important.
Yeah,
and
absolutely.
Calcified cases, especially calcified cases we're getting. And you mentioned this in your lecture with Torabinajad.
Yeah, exactly. I mean, for calcified cases, that gives you a little bit of a better measurement. So, all right, so let's talk about this case here.
Well, so with this premolar, this is tooth number 28, the lower first premolar. What we have is it's symptomatic. This lady came in, pain to palpation, swelling, probing was normal. Tooth was quite restorable, actually. So the vitality tests and the cold tests, everything was negative, indicating that there is a pulp necrosis with a chronic apical periodontitis.
So what's interesting, Manny, here is that not only you see periapical radiolucency, but you also see a large radiolucency on the mesial aspect of the tooth.
On the mesial. That's why I was really trying to capture some sort of pocket or loss of a periodontal attachment on the mesial, and there was none. And the other thing that's interesting is if you, by the angle that we took, we see that the anatomy is not typical. Which is actually is kind of typical for a lower premolar.
So you see that double roots, that means that it's going to be a trouble tooth. So, you know, triaging your cases, Manny, is so important, especially as a general dentist and a restorative dentist that was interested in just doing kind of cases where they're going to have good success rate. These are the type of cases that as soon as you see that on the radiograph, you really should refer to your, to your specialist.
They're not going to have fun doing a case like this.
No.
And sometimes, as we said, it could be misleading. You take a radiograph, the canal looks straight, then you take a different angle, and wow, you see all kinds of anatomy.
I mean, these are the kind of cases when I get, I wish I could refer to somebody else.
I know that we have no choice. We have to do that.
So I see, Manny, what you did here. So you are expecting this tooth to have a some kind of a bifurcation or even maybe a trifurcation or something like that. And so how do you manage these cases? You access, you get in there, and then what do you do? Well,
one of the things is you want to try and keep as much tooth structure as possible. But at the same time, you have to have access. So after getting the diagnosis, and once you have your diagnosis and all that, the root canal treatment, and when I do my access, I go in and like lower primols, are a little bit more on the buckle, really in the middle of the buckle incline, or actually lingual incline of the of the buckle cusp, if you like. And here we have a file shot.
Yeah.
I captured 2 canals, as you can see on this radiograph. But what you notice, and it's all about symmetry, is that the whole situation is not symmetrical. Ali's going to show you that.
Yeah, it's too far mesially oriented,
exactly.
right? So that you're expecting there's something more on the lingual. Depending on the angulation of your cone, the slob rule, right? It'll take you, if you took a mesial angle, this means that you should be looking on the buckle.
That's correct.
If you took it from a distal angle, you should be looking on the lingual.
So use a bit of slob use if you have good for optics as well, when you go in and probe around. Now, this could be a little bit challenging because of that, but what's important is to at least understand the anatomy. So for file shots, even if you have a good apex locator, file shot is super important.
So not only that, Manny, but as you have done here, coronal flaring, adequate coronal flaring, so that you could see that floor of this type of a premolar. The floor of the chamber in these types of premolars is fairly low, which is really why you need to really have a microscope, high magnification illumination in order to see that. Because for you to find that additional canal here, you pre-curve your small canal, and then you have to kind of walk it around.
You have to thread it and find it. A sharp explorer. We change our explorers often. We don't keep the same explorer all the time. We always change our explorers because they become dull. So an explorer is very important as well.
Terrific. So here you did this, you found it, and then you later on went on to find a third canal.
Found the third canal,
and
shaped, sealed.
Terrific.
And we see a puff on the meso. I see that often on lower premolars where you have some sort of exit mid-radicular areas, and you notice that the exit corresponds to the lesion actually.
Exactly. So that lesion was, I mean, the lateral canal in that specific location was an exit route for the infection inside the tooth. So just like at the end of apex in that tooth, there was another extra path for the bacteria to get out and cause a lesion on the side of the tooth. You really did a beautiful job with this. So how did you fill it?
Well, I sealed it. I used a warm lateral condensation at the time.
Yeah. Okay.
And with a type of it was a pulp canal sealer from that we used to use at the time, because this is a case that I did about 5-6 years ago, and we have some post-op radiographs.
And in the post-op, I see you've done beautiful healing here.
Here, this was a 3-year post-op, which is my last post-op. Then we lost touch with the patient. But here, what was key was trying to keep as much tooth structure as possible. We noticed that they changed the restoration. I don't know what they have between the gutta percha and the composite restoration, but often when your axis is small, one of the things that happen is a vapor lock. You get this type of bubble that forms. I recommend using a lentula with some sort of
with the composite material. Or better yet, use a small nozzle and make sure that you reach the base of the preparation as you backfill, the same way you would be doing with the obtura. The problem is a lot of times the restorative dentists use very thick cannulas for placing their core material, and it doesn't reach all the way down. I mean, whoa, look at the background side. If they use a flowable material with a thinner tip all the way at the base, they would have not had this issue, and then they would have brought it up a little bit farther up and then put a place the core on top of the flowable material.
Or even some sort of glass ionomer on top.
Exactly, glass ionomer. And actually, hopefully in the near future, with the endo-restorative material, you could use a fairly thin nozzle that'll go all the way to the base and have it. So here, as you can see,
I'll just interrupt you, but the challenges we have with cases like that is that apically, when your axis is small, you have less of apical control in the way, especially when you have different anatomy. And I wanted to keep it conservative.
That's terrific.
3-year post-op.
That's awesome. It's done a great job there. And the only thing here is that, as you can see, the sealer, the large sealer puff that you had is kind of over time is kind of going away. So, which is part of the problem with the zinc oxide eugenol cements, is that they're really not they wash out over time. So that's one of the negatives. So Manny, I know you have another case you wanted to share with us, but I think this place is turning into a little bit of a voice box.
The kitchen is opening up, and
so the kitchen's opening. Exactly. So let's go find a different location, because I'm sure everybody here watching might be a little bit losing their mind from all the noise in the background. Okay. Okay, so we've come and sitting outside here at a restaurant. We figured it's going to be a little bit quieter. I think it's actually louder out here. Got a little dump truck or something, and there's some construction on the side. It's fairly windy, so I don't know. We'll figure out if it's going to work out or not. But we're having another case. Manny had another case wanted to share with you guys with a couple of anterior teeth, right, Manny?
Yep. Actually, a case was referred to me for tooth number 8.
Yeah.
Because just to do apical surgery on tooth number 8 and possibly tooth number 7. Because on the radiograph, the angulation that my referring dentist sent me, she only had tooth number 8, a bit of number 9, a lot of number 7. So the lesion on 8 was kind of obscure, but we don't have it here on your...
So no, you actually, if you've taken the X-ray from the other tooth, it looks like the lesion's actually around the lateral incisor as well.
In other words, you have to take many radiographs, different angulations. I always suggest taking like 8 and 9 symmetrically if you're treating one of the incisors. And the other thing is we might think that the lateral incisor is affected by a lesion.
Yeah, so I mean, if somebody gave me this radiograph right now, I would think that this is the lateral incisor is the source of the lesion because the apex is in the middle of the lesion. But that goes to show that you don't ever judge a case by the radiograph alone. Radiograph is only one piece of the puzzle. You go on to take this, make a note of it, and then proceed with your systematic approach to diagnosis, which includes clinical vitality tests.
So, in other words, absolutely right. You need a pulpal diagnosis and a periapical diagnosis.
Right.
So good vitality tests.
So you do your vitality tests, which include your thermal tests, your hot and cold, little percussion tests, and so on. And at that point, from my understanding, is it ruled out the lateral because it was testing vital?
Both laterals in this case. Tooth number 7, actually, both lateral incisors were vital. Yeah. In this case, and the lesions actually came in. Pain to palpation was only affecting tooth number 9. Actually, 8. Because I'm getting the Canadian
so
way
the
mixed
Canadian
up.
numbering system is different.
11.
We've decided with Manny from now on, you don't call it a number. You just say a first molar, second molar.
So it's a right central incisor.
So that makes it a little bit easier. So the central incisor versus the lateral incisor. So basically, you did this. You found out that both the laterals appeared to be part of the lesion, but both of the lesions were caused by the centrals because the laterals weren't vital, and therefore the lesion had only expanded to include those. And one of the things that really helps you determine this was taking a CBCT.
That's correct, especially sagittal views.
Sagittal views, as well as in this particular case now you're looking at the coronal view that shows the lesion confined to apices of the two centrals. And here also in the sagittal view, you can see that there is a large lesion. There's a buccal perforation. There's no lingual perforation, right?
No, there's a...
And there's large posts.
And the probing was normal throughout. And what's interesting is that from a sagittal point of view, we notice how the fill is deficient, whereas when we took a PA, the fill doesn't look as bad. You see some deficiencies.
Yeah. No, exactly. You can see some, that's a problem in the past is you always judge cases from a buccal perspective, whereas we know from a mesial or an interproximal view, these canals are oftentimes much wider than a cone can fill, which is the whole idea of three-dimensional instrumentation and obturation. So these additional views here show the lesion expanding, and then you went on to decide whether you want to treat this surgically versus non-surgically. So can you tell me how you decided that you want to treat these surgically versus non-surgically?
Well, it was basically the coronal restorations were clinically sound, at least temporarily for now. But what scared me the most were those posts.
Yeah.
Removing those posts could cause some sort of complications. So the patient agreed for me to...
Yeah, and as long as the coronal structure is sound, and it does look radiographically, as you took from the sagittal view, that the quality of the fill at the apical area was not adequate, and given the large post, it's very possible using a ultrasonic to basically remove the entire root canal filling material apically, and then be able to kind of put a fairly long cone or thick plug of the bioceramic.
So judging from in this case, this gentleman had restorative work done for aesthetic reasons and some orthodontics too. So restorative was kind of recent. And it's only after the restorative work that things flared up. for instance, the right upper incisor. That's one of the things.
So that's actually a very nice piece of information. So the tooth blew up after recent restoration that was done, including the 2 big posts. So this is what happens when you have old root canals where the seal is inadequate, as we could see in the apical view from the sagittal sections, and you prepare a post space, and especially when you prepare a post space without a rubber dam, you contaminate that space.
That's correct.
And then you end up having, as soon as you post and you seal the top, the bacteria has nowhere to go but down. It looks like our breakfast is here too. Awesome.
Great.
Thank you.
Gracias.
Oh, look at that. Looks awesome. Perfect. Enjoy. Thank you so much. Okay, Manny. So let's quickly finish up this because the breakfast is getting cold. So you, this is what ends up happening, as we're talking about, is that's how these teeth get contaminated, right?
Yes.
Do you agree with that?
Yes. And but in this case, it's not the procedure, not the apical surgery, which was a challenge or something to learn from this. From this case, we can learn where lesions do seem to come in at times, overlap other apices of teeth adjacent to the source of infection. So it's important to do good tests and know your diagnosis.
Yeah, absolutely. Yeah. Terrific. So what you ended up doing here is you ended up doing apical surgery to go in apically, cut off a couple of millimeters from the end of the root, and then use your ultrasonic.
Use the ultrasonic, and I went up to the post.
Up to the post.
Up to the post, using a little, the ultrasonic tips are a little longer than the 3 millimeter ones.
Yeah.
And,
so that's really important, because going all the way up to the post ensures that at least up to that stage you have a very long plug of dentin that is clean and that has been removed the biofilm. So you disinfect that space and then you filled it, and you used did you use the lid technique here for the obturation?
In this case, I used the bioceramic putty, but I used the MAP system.
Oh, I see.
And it was kind of wide and easy, so I just wanted
Perfect.
to
So you just did the incremental addition of the thing and condensing it down. Terrific. Well, it looks great, and I can see that this is the final fill, and then
we have a 1 year.
And a 1 year follow-up. Look at the amount of bone fill that you have. You didn't do any bone grafting
No,
here.
not in this case, no.
Yeah.
No bone grafting.
And you didn't do bone grafting because...
Very conservative lesion.
Yeah.
It wasn't a through and through.
Only the buccal area, so it means that it's a 5-wall defect, and a 5-wall defect, placing a graft is really not necessary. It's just the body is able to heal itself. So placing a graft will only add additional cost to the patient, as well as the potential for...
It becomes like when you extract a tooth, there's a socket, it heals.
It should fill in. And it's even better than an extraction socket, because an extraction socket, the alveolar process is being held in place by the PDL. Here, this is basically just the buccal space that, once you put the flap back on, should just fill in with bone normally.
And then we have a...
So you have a post-op
I took a CBCT as well, and we see a bone through. This is a CBCT going through tooth number, the upper right incisor, and those are the sagittal views. I believe this is for the upper left incisor. Notice that bone heals right over the bioceramic putty, and the architecture is nice.
Yeah, so I mean, obviously, you end up having these bioceramic class of molecules. You end up having a cementum grow over the years. This is the study by Dr. Kim showed in 2015. Study by Dr. Kim on dogs showed that bioceramic. You have cementum growing right over the bioceramic material.
You can't get better evidence than that the thing is biocompatible.
Exactly. When you have cells growing right over. So that's terrific. Manny, our eggs are getting cold. Let's get to it. All right, thanks. All right, man, that was a pretty good breakfast.
That was good.
So really I'm gonna just pick your brain. Huevos, rancheros, or cheesecake. I just want to pick your brain from one final case that you wanted to talk about, and that's that interesting second molar that
first molar,
you showed me. Was it the first?
No, second molar.
Second molar. Come on, that's not a Canadian number.
Right.
You can't get away with that mistake. Right. Okay, it was the second molar you showed me, adjacent to a third molar, and this tooth you told me had a fracture or something like that, right?
It was necrosis, pulp necrosis of the upper left molar. upper left second molar.
Right.
And there was a pocket, a loss of attachment on the mesiolingual of the tooth. There's about a 6 to 8 millimeter pocket, very localized in the area.
So we got a pocket going on, and then you went in there, you told me that it was cracked or something, and you decided that it's an end-stage tooth, right?
Yeah, we call it
end-stage, you remember that? End-stage tooth.
That we spoke about in the cab.
We spoke about in the cab, yes.
But we didn't.
So the terminology you're using here is an end-stage tooth, where a tooth cannot be saved.
It's not salvageable.
That's it. We should make this jargon for our profession. A tooth that cannot be saved from now on is going to be called an end-stage tooth.
Ali, I'm sorry to disappoint you, but that name has been already coined by someone.
A terminally ill tooth?
Was it Kim or someone? Someone already coined that
Kim.
term.
Somebody has coined the term.
Yes.
We're not taking credit for it, but it's okay to share it. An end-stage tooth as a tooth that is, look, we've done all we could do, but we just
nothing could be done.
We got to put this tooth down.
Exactly. It's true. But we didn't coin it. Someone else did.
Yes.
I'm trying to recall who.
Okay, so that's the term, a tooth that's non-salvageable. Okay, so you decided this tooth has to be removed.
That's
so
right.
what's the next thing? Obviously implants, is that the plan?
I recommended extraction, possibly with an implant, and I also gave another option. As you can see, patient agreed that we treat the wisdom tooth right behind it, actually distal to that tooth.
Okay.
Tooth
So
number 16 in the US.
Yeah.
Right? So what I did was 16 intact, almost a virgin tooth, and I did a small access through that wisdom tooth on the upper left. Did the root canal treatment, filled the whole thing with an amalgam, extracted the second molar, cleaned the area, extracted the wisdom tooth, as you can see on the radiograph. I extracted it, put it in hanks for a couple of seconds, for about a minute or two while I was cleaning out the socket of the second molar.
Preparing the sides?
Reimplanted on the site of the second molar, sutured it into place with a silk suture. Now, the reason why I went for that tree plan is because if you look at the configuration of the roots, they're very similar. In this case, the molar, the wisdom tooth, and the second molar are very similar in configuration, similar architecture.
all right, so basically,
And notice I broke a few root tips. You can see on the radio.
yeah. So what ended up happening, you decided to transplant this tooth because second molar was not salvageable, and there was a viable third molar adjacent to it.
Which
so
is
you
less
first did the
strategic.
so you did the root canal first on the third molar, and then transplanted it. As you said, there was a little bit of a segment was left in
noticed,
there.
yes.
No big deal. I guess at that point it was a sterile tooth anyway.
Yes.
And you have a follow-up here too.
This was a 3-year follow-up.
So a 3-year follow-up
This is my last
shows
follow-up until I
excellent
lost touch
healing.
with the patient.
So this is an interesting case where you actually decided to transplant the tooth instead of removing it. One of the things I found is this procedure works when you have nice conical roots where you can kind of replace the, once you remove the tooth, the socket that is present doesn't have to be too manipulated, and that the roots of the tooth that's going to replace it are going to easily slide in there.
Yes,
right?
so in the treatment plan, you want to make sure the roots have a similar configuration, conical, so that things don't break.
Yeah.
And the other thing is the difference between this type of extraction. I wouldn't call it an atraumatic extraction. I would call it a regular type of extraction. Just that you're not going with, you're going around you're breaking or cutting the fibers, the circumferential fibers with a blade. Because you want to keep everything nice and clean. And you do a slow extraction, and then you...
Exactly, do your fibrotomy and the gingivectomy in a way that is very and the removal of the tooth is very atraumatic. So how did you stabilize the third molar after you reimplanted it?
The third molar area, I put a color coat inside. I didn't have to do that. And
how did you stabilize the reimplanted tooth?
With a thick 3-0 suture, silk suture.
So you did a figure eight over it? Yeah,
figure eight
exactly.
And,
terrific.
Which I removed about 2 weeks after that.
So you removed that a couple of weeks.
For a week.
Paradex for a week. Antibiotics?
No antibiotics.
No antibiotics in this case? Okay.
No antibiotics. I was concerned about the loss of attachment that I had with the original second molar, and thought maybe because of this loss of attachment, is this reimplanted tooth going to work? And at my third year recall, the tooth was an occlusion, and it resonated quite normal to percussion, meaning there was no evidence of replacement resorption or ankylosis. And I was surprised to the way it worked. And I'm wondering, you have to look into statistics and what the data shows about reimplantation versus an implant.
That's a very good question. There's, obviously the original studies on reimplantation, Dr. Lee Grossman's studies show that, you can have in the 80s success rate with a tooth that gets reimplanted as long as the reimplantation is done quickly and atraumatically. The techniques have improved. Newer probably studies show a higher success rate with the atraumatic extraction methods and so on. So that's, if reimplantations works, the transplantations, I guess, is the next step forward. There's another trick too, to prepare the site for these lesions. You currently can use CBCT technology to print a model of the wisdom tooth, so that prior to removal of the wisdom tooth, after you remove the second molar, you can actually use the printed model to see how it fits.
Ah, yes, especially with the 3D print. That's
right.
Coming up.
You can 3D print the third molar based on the CBCT, and then check your fit after the extraction, so you don't end up extracting the third molar only to find out that it doesn't really fit. Now that's pretty embarrassing if that happens.
In this convention, in this event in the
AAE meeting this year,
there's a lot of talk about the reimplantations and different ways of preserving teeth, because endodontics is not just root canals, it's different ways of preserving our dentition. That's a specialty. It was fun having breakfast with you.
Hey, absolutely, man. Exactly, the Union Station in Denver as well. And thanks for the thing. I'm sure everybody appreciates it.
It's a pleasure. Thank you.
See you soon, man. That guy's great, I tell you. Jesus. Damn. Okay, so it's actually, this has turned into a monster project of a blog here. I've been editing this. This is the day after the AAE meeting. I stayed an extra day at my hotel after the AAE and just kind of editing and getting all the stuff together for this monster project of a vlog at the AAE. So I'm starving right now. I'm just gonna go grab a quick bite to eat and basically say goodbye after that. It's just I've spent a whole day here, and it's probably still take a little bit of time, but it's almost done. But I enjoy doing this stuff and sharing these videos with you. And from what I gather from these meetings, so many of you guys come to me and say how you enjoy these videos, so I feel it's worth it to me. So. Chris's, and it looks like I'm going to be basically rewarding myself after a whole day of editing. Well, it looks like our vegetarian dish is ready over here. I'm going to have a setup. Cheers to you all. Thank you so much for following me in this video. In the meantime, let's save some tea.